Hello everyone, let's look at how to manage resistant hypertension through case-based strategies. Let's begin with the scale of the problem. 1 in 4 Indian adults have hypertension, but less than 12% have it under control according to the WHO. Over 90% of hypertensive adults remain uncontrolled. This is a crucial reality, especially for our patient population. Chronic kidney disease only increases the complexity in management of hypertension. Here is a typical case scenario. We have a 57-year-old male patient, obese, diabetic, hyperlipidemic, presenting with persistently high office blood pressure readings, 160 by 95 millimeters of mercury, despite being on a multi-drug regimen, that is calcium channel blocker, thiazide diuretic, ACE inhibitor, and beta blocker. Ambulatory blood pressure monitoring and home monitoring confirms persistent elevation and secondary causes have been ruled out. This is classic true resistant hypertension. Elevated blood pressure despite optimal doses of 3 different antihypertensive medications, including a diuretic. Let's succinctly define resistant hypertension. It is blood pressure of more than 140 by 90 millimeters of mercury despite 3 antihypertensives, one being a diuretic. Controlled resistant hypertension requires 4 or more drugs. Remember, high-risk patients, that is elderly, 10-year cardiovascular disease history, diabetes, CKD, all of these patient groups require more aggressive treatment approaches. The prevalence of true resistant hypertension is 10.3% overall, but much higher in patients with chronic kidney disease, renal transplant, and elderly. Adherence falls dramatically after 1 year. Fewer than half maintain prescriptions accurately. Consequences are dire, including end organ damage, stroke, heart failure, higher admissions, and reduced life expectancy. Interventions include patient education, digital monitoring, simplifying drug regimens, and frequent clinician contact. Always directly ask patients about adherence and use objective tools where possible. Distinguishing pseudo-resistant hypertension from resistant hypertension is absolutely crucial before escalating therapy or ordering expensive investigations. True resistant hypertension is defined as blood pressure that remains above target despite adherence to at least 3 antihypertensive agents of different classes, including a diuretic, at optimal doses and after ruling out secondary causes. Pseudoresistance, on the other hand, is often the result of factors that mimic drug resistance but can be corrected. The main culprits include medication non-adherence. Up to 87% of patients with apparent resistance may not be taking medications as prescribed. Improper blood pressure measurement technique. Office or home readings can be falsely elevated if done incorrectly, so always ensure standardized technique. White coat effect. Office readings may be high, but ambulatory or home monitoring could reveal normal values. And clinical inertia. Reluctance to intensify treatment despite uncontrolled blood pressure. Suboptimal drug regimens or dosing, that is, not using optimal doses or combinations, or missing inclusion of a diuretic. So this is how we rule out pseudo-resistance hypertension by excluding white coat effect. This can be done by ambulatory blood pressure monitoring or home blood pressure monitoring. White coat effect is nothing but high blood pressure in office BP readings, whereas home blood pressure monitoring is normal. We also have to assess for poor adherence to treatment by monitoring medication refills, counting the pills, screening the blood or urine for drug levels. Use proper office blood pressure measurement techniques, that is, staying rested for 5 minutes, quiet room temperature, appropriate cuff size, average of 2 or more readings. Blood pressure should be measured in both the arms and exclude brachial artery calcification. So this is correct blood pressure measurement technique. Patients should sit relaxed for at least 5 minutes with an empty bladder without talking. They should not have consumed caffeine, smoked, or exercised in the last 30 minutes. Use a device that has been properly calibrated and a proper sized cuff. The bladder should wrap around 80% of the patient's arm. A small cuff will result in higher blood pressure readings. Take measurements in both arms on bare skin with the patient's arm supported. Use the arm with higher reading for subsequent readings and repeat measurements 1 to 2 minutes apart. Use the average of at least 2 readings obtained on at least 2 occasions to estimate the blood pressure. So our approach is to reassess the regimen for optimization and possible side effects, rule out secondary causes, especially in our renal population. Consider adding a mineralocorticoid receptor agonist or centrally acting agent. Use ambulatory blood pressure monitoring and regular follow-up for office and nocturnal blood pressure monitoring. Always emphasize on lifestyle modifications and adherence. Even if current habits seem good, patients may overestimate compliance. Here is another case study. Here's a 62-year-old female with office blood pressure of 160 by 100. BMI is 28. Diagnosed hypertensive for 15 years but struggles with adherence, missing doses, irregular intake, and has high sodium diet. Ambulatory blood pressure monitoring confirms uncontrolled blood pressure, but the main issue is non-adherence and excess salt intake. Management is often behavioral in such situations. Continued education on medication timing and dosing, encouraging dietary changes, reducing processed foods and salt, structured follow-up to reinforce adherence and lifestyle modifications. Remember, in real-world practice, the prevalence of non-adherence ranges from 7 to 87% among resistant hypertension cases. Screening for non-adherence is crucial by utilizing pill counts, refill data, patient questionnaires, and occasionally drug level measurement if available. Medication non-adherence remains a major barrier to effective blood pressure control in patients with resistant hypertension. It is estimated that less than 50% of the patients continue to take their prescribed antihypertensives as directed 1 year after initiation. Studies report a broad prevalence of poor adherence ranging from 7% to 87% in resistant hypertension. The consequences of non-adherence are profound, including increased risk of end organ damage such as microalbuminuria, stroke, heart failure, higher rates of hospital admissions and healthcare costs, reduced quality of life, and increased mortality. Before escalating therapy for presumed resistant hypertension, always assess medication adherence. Non-adherence can masquerade as treatment resistance, causing a pseudo-resistant hypertension scenario. Addressing adherence can significantly reduce overtreatment and prevent adverse effects from unnecessary polypharmacy. Several methods exist to identify non-adherence. Direct observation of medication intake, medication event monitoring systems using electronic pill bottles, measuring drug levels in blood or urine, use of digital medicine tools integrated with smartphones or devices. More practical clinical tools include patient questionnaires, interviews, pill counts, and prescription refill analysis. Many reliable methods are costly or time consuming, thus, combining simple tools with clinical judgment is essential. Here are some strategies to improve adherence. Educate patients on the importance of regular medication use and consequences of missed doses. Simplify regimens to once daily dosing when possible. Use reminders, pill boxes, or digital aids. Address side effects proactively. Follow-up visits should reassess adherence regularly and provide ongoing counseling. So the take-home message is that medication adherence is the foundation of effective hypertension management. For nephrologists working with resistant hypertension cases, confirming and improving adherence is one of the most impactful interventions we can make to improve patient outcomes and avoid unnecessary medications escalation. So this lady has resistant hypertension due to lack of medication adherence and high salt intake. Her hypertension is not adequately controlled due to inconsistent adherence to prescribed medications and a diet high in sodium. Management is by educating about the importance of consistent medication adherence and the role of salt restriction in managing hypertension. Advice to reduce salt intake by avoiding processed foods, using alternative seasonings, and being mindful of sodium content in restaurant meals. Regular follow-up appointments to assess blood pressure control, review medication adherence, and reinforce lifestyle modifications. Here is a 62-year-old woman, long-standing hypertension and diabetes, now with recently diagnosed chronic kidney disease and uncontrolled blood pressure despite multiple medications. The clinical findings consistently show high office blood pressure values, fatigue, ankle swelling. She is on both ACE inhibitors and a thiazide diuretic with good medication adherence. The investigations show that the ambulatory blood pressure monitoring is showing persistent hypertension, including nocturnal elevation. Renal functions show that there is increased creatinine, reduced eGFR, and proteinuria, confirming CKD progression. There's no evidence of renal artery stenosis. The key points are over here are that resistant hypertension in chronic kidney disease is multifactorial. In this patient, exclusion of non-adherence and secondary causes confirms the true resistance necessitating tailored therapy and dose monitoring for renal and cardiovascular complications. So this is clearly resistant hypertension due to secondary hypertension, that is chronic kidney disease. Resistant hypertension is common in chronic kidney disease. Masked hypertension is present in 30% of the patients with CKD and is more likely to be associated with resistant hypertension and end organ damage. Masked hypertension is hypertension that is recorded during home BP recordings, but the office blood pressure values are normal. Resistant hypertension is associated with greater risk for kidney disease progression. Non-dipping or even rising nocturnal blood pressure is associated with increased cardiovascular disease morbidity and mortality and increased risk of chronic kidney disease progression. Chronic kidney disease increases blood pressure through several mechanisms such as increased sympathetic tone, upregulation of RAS, increased salt sensitivity, endothelial dysfunction, and increased arterial stiffness. Here is a summary of recent blood pressure targets recommendations by international societies and recommended first-line antihypertensive treatments. So as you can see, the recommendation is usually less than 130 by 80 or sometimes less than 140 by 90, such as in elderly patients. And the first-line drugs are usually calcium channel blockers or RAS inhibitors or diuretics. So here is the treatment strategy of hypertension in chronic kidney disease. Blood pressure target of less than 140 by 90 to all patients and if tolerated less than 130 by 80, especially in young or proteinuric patients. Lifestyle changes are the first line. Avoid NSAIDs. Start with RAS blocker plus calcium channel blocker or diuretic, a combination therapy. Followed by that, you can add either a calcium channel blocker or a diuretic if BP goal is not achieved. If there is resistant hypertension, add spironolactone or other diuretic or a alpha or beta blocker. Consider nephroprotection and cardiovascular risk reduction. In patients with chronic kidney disease and diabetes, SGLT2 inhibitors are first-line anti-diabetic agent. Finerenone can also be added. Chronic kidney disease and no diabetes, SGLT2 inhibitors should be added because of proven cardiorenal protection. So keep in mind that combining ACE inhibitors and ARBs is not recommended. Follow potassium and creatinine closely when prescribing an aldosterone antagonist. Loop diuretics or thiazide-like diuretics are preferred when GFR is less than 30 ml per minute per 1.73 meters square. Consider new potassium binders in patients with hyperkalemia. This is a stepwise evaluation algorithm recommended by the American Heart Association for Resistant Hypertension. Step 1 is to confirm treatment resistance. First, ensure the diagnosis fits. The clinic blood pressure should remain beyond 130 by 80 millimeters of mercury, despite the patient taking 3 or more antihypertensive agents, usually including a long-acting calcium channel blocker, a renin-angiotensin system blocker, and a diuretic, all at maximal or maximally tolerated doses. This step helps prevent overdiagnosis if suboptimal drug dosing is used. Step 2 is to exclude pseudo-resistance. Before escalating, rule out pseudo-resistance. Confirm adherence to the prescribed therapy. Non-adherence is a frequent cause of apparent resistance. Utilize 24-hour ambulatory blood pressure monitoring to exclude a white coat effect. which can falsely elevate clinic readings. Or you could also use home blood pressure monitoring. Step 3, assess for secondary hypertension. Once true resistance is established, search for secondary causes. Renal causes such as parenchymal disease, renal artery stenosis, endocrine causes such as primary aldosteronism, pheochromocytoma, Cushing syndrome, obstructive sleep apnea, coarctation of aorta, and other rare endocrine disorders should be considered if clinical suspicion arises. Step 4 is to assess for target organ damage. Resistant hypertension carries higher risk of end organ damage. Always evaluate the eyes, perform a fundoscopic examination. Heart, assess for left ventricular hypertrophy and coronary artery disease. The kidneys, look out for proteinuria and EGFR. Peripheral arterial disease, check the ankle brachial index. So in this third case where resistant hypertension was because of chronic kidney disease, renal protection strategies such as addition of ARBs or ACE inhibitors could be helpful. Now here is another case study. We have a 45 years old male with hypertension, type 2 diabetes and hyperlipidemia. The issue is that he has persistently high blood pressure despite being adherent to maximally dosed ACE inhibitor, thiazide and beta blocker. Comorbidities, diabetes and hyperlipidemia, but they are well controlled. Investigations show that ambulatory blood pressure monitoring confirms sustained and nocturnal hypertension. Echo shows no hypertensive heart disease. Renal function is normal. Lipid profile, he's on statins. So this is resistant hypertension as his blood pressure remains uncontrolled despite optimal doses of 3 antihypertensive medications from different classes. So as you can see here, this slide lays out the stepwise antihypertensive strategy recommended by the European Society of Cardiology and European Society of Hypertension 2018 guidelines. This slide lays out the stepwise antihypertensive strategy recommended by the European Society of Cardiology and European Society of Hypertension 2018 guidelines. Step 1 is initial dual combination. Start with ACE inhibitor or ARB plus a calcium channel blocker or diuretic. For low risk grade 1 hypertension, elderly patients more than 80 years or very frail patients consider monotherapy. Step 2, triple combination. Progress to a triple combination, that is ACE inhibitors or ARBs plus calcium channel blockers plus diuretic, ideally a single pill combination. This maximizes blood pressure reduction and improves adherence as well. Step 3, add spironolactone or another agent, that is 2 pills totally. If blood pressure remains uncontrolled, add spironolactone 25 to 50 milligrams per day, or if not tolerated, choose another diuretic, an alpha blocker or a beta blocker. At this stage, the patient meets criteria for resistant hypertension. Some additional steps: if hypertension remains uncontrolled, refer to a specialist center for further investigation for secondary causes, checking for adherence and for advanced therapies. Beta blockers can be considered at any step only with a specific indication such as heart failure, angina, post-MI, atrial fibrillation, young women with pregnancy. So as you can see, calcium channel blockers are in the first step as well as the second step. Calcium channel blockers have been widely used in clinical practice for managing hypertension. In hypertensive patients with or without chronic kidney disease, calcium channel blockers are effective antihypertensive drugs. They can be used alone or in combination with an ACE inhibitor or ARB in hypertensive patients with preserved renal function or with chronic kidney disease. The guidelines recommend calcium channel blockers in combination therapy to improve blood pressure control. As you can see, there are many guidelines from Europe, Taiwan, Canada, USA, and China. All of these guidelines recommend calcium channel blockers in combination therapy. So in case 4, the solution is to add a calcium channel blocker as the patient is not on calcium channel blocker. Thank you.